My name is Evan Walsh. I am currently a third-year resident at University Hospital's Cleveland Medical Center. I'm doing my emergency medicine residency right now, and today I am doing a presentation on the red eye and evidence-based medicine around this and how it refers to the red eye in the emergency department and our emergency care. Part of this was done trying to put together a clinical practice guideline in order to be able to help streamline the approach to the red eye and what we can be doing in the emergency department to help treat these things, and when we do and don't have to consult ophthalmology, and when our best time would be to transfer potentially or speak to somebody about going somewhere else if you're working in the community. So some objectives for this presentation today is really to help develop a clinical algorithm to get to the bottom of the differential diagnosis for the red eye in the emergency department setting specifically. We're going to discuss branch points in this diagnosis using our history, a physical exam, and some pretty readily available clinical tools that are used in most emergency departments and are available for most people in the ED. Part of this is us reviewing anatomy in terms of the eye and the orbital soft tissue, because that's going to play a big part into helping to make a diagnosis here. Same thing with the anterior chamber of the eye. A lot of the posterior stuff, whether it's the retina, the vitreous, those kinds of things are not going to be discussed here, just in this case because it's not really going to present as a red eye. So, like I was saying, the big part of this is going to be going through the anatomy here and taking a look. We've got two different pictures here, one on the left, one on the right, and then they're going to show a couple different things. So the one on the left is a pretty good picture of just general eye globe anatomy, whereas the right one is going to give us a little bit more of the general orbit and soft tissue anatomy. So if you're taking a look at the left, I think it's important to see that there's different layers there, just like you would have skin anywhere else on the rest of your body. You have the cornea, you have the lens there that are structures that are going to help us be able to see things, whereas if you look at things like the sclera and the actual conjunctiva there, those are things that aren't necessarily going to help us see, but they are things that are going to turn red for us, so it's going to be important to help differentiate between the two of them. The big importance is if you take a look at the conjunctiva, it's all the way on the outside of the eye, because the eye needs to be able to see, and because it needs to be clear, you have to be able to see through it. So that's the big defining feature of this conjunctiva, is it doesn't actually have any blood vessels because it's clear, so there's no blood vessels running through it. So if you see anything red in that eye, it tends to not just be the conjunctiva itself. It tends to kind of tell you more information about what might be going on underneath. And as you go deeper in, you're going to run into more blood vessels. So with blood vessels brings nutrients and brings pain sensation. So since the conjunctiva doesn't really have any sort of vasculature going there, it's not able to send any signals out in terms of pain. So if something is isolated just to the conjunctiva, it's typically going to be non-painful, which is going to be a big differentiating feature between a lot of the differential diagnoses we're doing. Whereas if there's some sort of inflammation of the muscle, the iris, and changing pupil size, that would be painful when it moves. And same thing with the sclera, where if you take a look at the right, now we're looking more at the anatomy of the actual globe. Sorry, not the globe, the actual orbit itself. The big defining feature here is if you take a look at that orbital septum right there, that helps to differentiate really two different areas of the face. So on the outside, if you get some sort of infection on the outside, whether it's a cellulitis or something on the skin of the eye, it is very difficult for that infection to then spread backwards past this septum. So when we're differentiating different types of infectious causes, if that eye and that surrounding area is red, it's going to be important for us to know whether it's in front of that septum or it's behind that septum. And the big differentiating feature is, again, pain. So If there's something behind that eye, behind that septum, if you take a look at that picture, it makes sense that as the eye moves, it's going to irritate that area with infection, and it's going to be painful. Whereas something on the outside of that septum, just like a straight, regular preseptal cellulitis, doesn't affect or doesn't really touch the eye in that same way, so it's not going to be as painful. We're going to take a look at these couple tools here. These are those tools that I'm pretty sure everyone's going to be able to get in the emergency department in some sense to be able to help make these diagnoses. And as we go through the rest of the presentation here, you'll see little smaller versions of these pictures in the corner just to help us kind of have a reminder of what we can use to help diagnose specific plans and different differential diagnoses. So our physical exam is really going to be the bread and butter of how we make this diagnosis and help differentiate between things. Of course, the vital sign of the eye is visual acuity. Whether it's affecting someone's vision is very important. Are they able to see fingers? Are they able to read words? Are they able to actually help take a look at that Snellen chart and help participate and get that visual acuity there? Or they're not able to see anything at all. Pain is going to be a real big branch point for us. Does it hurt? Does it not hurt? And when does it hurt? If it doesn't hurt all the time, which is important with the extraocular movements too. So are the extraocular movements intact? Are you able to move the eye around? If not, then you'd be worried about some sort of entrapment potentially. Does it hurt when you move your eyes? And the same thing with the pupillary exam. Are they reactive? Are they the same size? When you shine a light at it and the pupil contracts, does that cause pain in that eye? Does it cause pain in the other eye? Or does it cause pain in both? And the laterality of things are going to be important, whether it's one side, whether it's two sides, in helping to differentiate what might be causing something to happen. So one of the big ones, big red eye, painful, is the acute angle closure glaucoma. This is one of those ocular emergencies that you need a tonal pen to diagnose. Typically when people come in, they'll be coming in with pain of that eye. They'll have decreased vision, and you'll see what you see here on the picture, that one of those eyes tends to be more dilated than the other one. It's stuck open and it closes that angle, which is causing the buildup of the pressure. You need the tonal pen to be able to figure this out, and that's helpful because excuse me, it's not just a positive diagnostic test. If you take that tonal pen and your pressure is 50 in that eye and it's very, very high, then you've got this diagnosis right here. But if someone's taking a, like their eyes look just like this, and then you get a pressure in that eye and it's normal, then you might have to start thinking about something else. You can't exactly have glaucoma if your pressure is not elevated. So that's the big differentiator for acute angle closure glaucoma. Corneal abrasions are something that we hear about a lot. Something scratches the outside of that cornea, and we help diagnose this by using fluorescein. We put some tetracaine in the eye to help numb things up if this is painful in the first place. Like we were saying before with that picture of the eye, if it's just related to the outside, you don't necessarily always have pain. If you have a deep corneal abrasion or something like that, it might get into the lower layers of the eye and cause some pain. But if it's just related to the cornea, it may not actually be painful. It may feel like there's something stuck in there. It may feel like it's dry. But the only way that you're going to be able to tell is hey, dry eye conjunctivitis, or is this something scratching? Is to use that fluorescein. For this case, you can use a slit lamp if you want, but you should be able to make this diagnosis by just using a Woods lamp. Taking a look at this corneal ulceration, though, this is not something that we should be diagnosing on our own. This is something different than the scratches before. You can see it beginning to ulcerate out there and spread. So the concern with corneal ulceration is infection. Specifically, I think a lot of times with eyeglass and contact lens wearers, if they are contact lens wearers, you have to cover for Pseudomonas. However, this is something that you should talk to ophthalmology about before you do anything else. Sometimes if they're able to come in, this is something that you have availability of ophthalmology for, they'll sometimes want to come in and take a culture of the ulceration before they start on antibiotics. However, if you are somewhere out in the community and you don't have easy access to ophthalmology like that, this is definitely something that you should discuss with them before going further. The open globe is the next kind of step on this. You have the little scratches, it starts to ulcerate and go deeper, and now that you've gotten to this open globe, now you have a hole in the eye. Same thing as before though, you're using that fluorescein, you're using the slit lamp here. It's going to be a little bit difficult to do the with lamp to get a full great exam for this. You can see on the right the fluorescein that we're using. So this is when we talk about a Seidel sign. So a Seidel sign is what you're seeing here on the right, where you're seeing leakage of fluid coming down from the hole in the eye caused by, probably in this case, some sort of foreign body. But if there's a trauma patient, a car accident, something like that with blunt trauma to that area, it might not be so clear right in the middle. It might be elsewhere in the eye. So you do have to get a good look around if they're able to open that eye up. If you take a look at the left, this is another finding that you can see in an open globe, is that tear-shaped pupil right here. And you can see it's actually because it's almost like a herniation of the iris there through that hole, causing the pupil then to be directed towards that herniation. So if you see someone that doesn't necessarily have this great of a picture here for it, that tail or that point of the pupil should point you towards the area that's injured, the area that's open. This is something that ophthalmology needs to see. This is an ocular emergency and something that needs to be dealt with pretty quickly and very likely transferred out if you don't have ophthalmology in-house. Next thing that we can use this fluorescein and the slit lamp for are keratitis. A lot of times we think of herpes ophthalmicus or HSV, keratoconjunctivitis, that looks like the branching lightning type viral infection here. So this is something on the right that we see a lot in books. This is something that we have to treat with antivirals. This is something that you have to talk to ophthalmology about because they'll often want to do their own exam, possibly transfer to get this done if it's reasonable, and potentially start on oral antivirals, or depending on how significant that infection is, they may actually recommend IV antivirals as well. Whereas on the left, you see that UV keratitis. It doesn't exactly have that same branching pattern that you can see on the right. It looks more of a snowstorm, little spots that kind of coalesce together. This is actually something that people get if you're out like skiing with all of the reflection off of the snow into your eyes, or people that weld, people that go into tanning beds that don't wear those fancy little sunglasses. This comes on actually later, so it's not going to be someone that comes straight from the tanning bed with this right afterwards because they can't see. They might actually come in the next day, 12 hours later, with these symptoms. And this actually starts to get better on its own, as long as you don't have that continuous exposure, because it's really cumulative. And if you give it some time, a day, 2 days, it tends to start healing on its own. This is something that you can have them follow up with ophthalmology as long as they're still able to see well through it. And here we have our corneal foreign body. So this can be similar to the open globe, but it doesn't necessarily penetrate all the way through. So the important thing for this is to differentiate between a foreign body that did cause an open globe or that did not cause an open globe. So you want to use your fluorescein and your slit lamp here, and it's going to be important that you use your slit lamp because you really want to look around and make sure that there isn't any sort of Seidel sign. So depending on what it is, if this is something that's very superficial, that you can take a look, you get a good lateral view, like the picture on the right, that you can tell is very superficial, doesn't go all the way through, doesn't have a Seidel sign, this is something that you should be able to remove by yourself in the emergency department. Oftentimes you can get a Q-tip that's moistened a little bit with some saline, or even a 25 gauge needle, and scrape part of that without actually sticking the needle directly at the eye, and that should be able to come out. If it doesn't, that's something that you can talk to ophthalmology about. If you're concerned of it going deeper, such as, say, now you're having some pain there, not just an irritation, that might tell you it's going deeper. This is something that ophthalmology needs to see. This is something that I would have low threshold to talk to ophthalmology about. If it's in the center of their vision, if they're having a painful reaction to it, this is something that should often require outpatient follow-up in a relatively quick time period, especially if it's something that's metal that can then cause a rust ring afterwards. If that rust ring that encircles that area around that foreign body is in the center of the vision, that's actually something that should be seen by ophthalmology, because it's potentially life or limb threatening, in this case vision threatening here right in the middle of your eye, that can cause some further issues if it's not dealt with relatively quickly. Usually this is something, if it's in the middle of the eye, talk to ophthalmology. They'll usually try to get them in within the next day or two to see what they can do about it. And sometimes that can actually, if there is some sort of inflammation there, you can get a little bit of a white ring as well, which is just white blood cells. So this one, this subconjunctival hemorrhage, you just look at it, it's a bruise in the eye, and that's it. You don't have to do anything else about it. It should go away in a couple weeks. If this is somebody that gets this all the time, you might want to consider some sort of coagulopathy, connective tissue disorder, but otherwise there shouldn't be anything for you to worry about with this. So here's a big differentiator of something that looks the same. So we have scleritis or episcleritis. If you remember back to that picture I was showing you at the beginning of where the sclera is, the sclera is underneath that outside layer. This is a part of a layer that has blood vessels here. So if there's some sort of inflammation of the sclera, it's going to be painful. Whereas episcleritis, or inflammation of the episclera, is actually an inflammation of a layer between the most outer layer of the eye and the sclera. So this is still something that's clear and not something that is necessarily painful. It might be a little bit irritated because you have some of the blood vessels that you can see on the right with the episcleritis, but it would be more of a dry eye irritation here, whereas that left one, true scleritis, is going to be extremely painful. People will say that it feels like someone's drilling through the side of their head there, which is a very different presentation than the right side. And a lot of times scleritis usually just happens in people that have some sort of autoimmune disease, whether it's rheumatoid or lupus or vasculitis just in general, but it's going to be very, very painful. You want to use anti-inflammatories for this. This is something that you need to talk to ophthalmology about. The reason that I put tetracaine up here is that because this is a lower layer, if you put that tetracaine in, it won't necessarily help. This is a way that you can help differentiate between the two of these. If it is something that's more superficial, like the episcleritis, and they have some irritation and pain with it, if you give them tetracaine, it might get better. But that scleritis is really an inflammation of that layer, and just putting tetracaine on that isn't going to make all of the pain go away. Another thing that you can see on the left, that sclera, is there is a white or less red area surrounding the iris there. So the limbus of the eye is spared from this inflammation. So it's called perilimbic sparing, which is something that is specific for scleritis because that layer doesn't extend that far. The episcleritis, you can see, gets a little bit closer on the right because that second layer doesn't stop necessarily at the same spot. Another way that you could attempt to differentiate the two of those if you're really stuck is the episcleritis has vessels that are more superficial, whereas the scleritis has something that's more deep. So theoretically, you could even take a Q-tip or cotton-tipped applicator and put it on the eye and attempt to move the blood vessels around. If you're able to move those blood vessels around, that would be more consistent with an episcleritis than a scleritis, which has those blood vessels much deeper in there. And now this leads us to iritis, so inflammation of the actual iris, or it's also uveitis. You're pretty much interchangeable here. What this is inflammation of the anterior segment of the uveal tract, or it's usually something from something inflammatory, but you can get traumatic iritis with blunt trauma or something like that. One of the telling signs of this is when you do your slit lamp exam. If you take a look from an angle, you should be able to see something called cell and flare. This is when there's white blood cells released into that anterior chamber of the eye. You can actually see the light from the slit lamp glancing off of them, almost like if you had dust in like a spotlight or something like that, where you could see it kind of raining through it. That'd be something called cell and flare. And as you can see, this is different than that scleritis before, where this does not have that perilimbic sparing. This goes all the way around. So if the iris gets bigger or larger, if the pupil does the opposite, this is going to cause pain. So you're going to have consensual photophobia. You put light into the other eye. When you get the consensual photophobia on the eye that's hurting you, you're going to have pain there because the iris is moving and the iris is inflamed. So typically it tends to be a little bit less reactive to try to minimize that, but that doesn't necessarily mean it's always going to be that way. And if you have really, really bad iritis, you can actually get a hypopion, or the buildup of the white blood cells that kind of fill the bottom of the anterior chamber. That brings us to conjunctivitis here. So this is going to be different than a lot of things that we spoke about before. This is just an inflammation of that conjunctiva, so it's always going to be non-painful. You're not getting any deeper than there, you're not getting any blood vessels, so this should not hurt you or your patients, but this will be something that's often irritating. It might feel like you have very dry eyes, and there's these three generic causes of it. Straight in the middle, that bacterial conjunctivitis, or that pink eye, that's going to be obviously bacterial, and you're going to have some purulent discharge from there. This is not something that you really see in very many other disorders here, especially the conjunctivitis. The other ones are going to give you some watery discharge, but nothing should give you that purulent discharge other than bacteria. I mean, this can be unilateral, this can be bilateral. You only have to treat the eyes that actually have purulence coming from it, but a lot of times this happens in kids, so they'll scratch one eye, scratch the other one, and it'll often be bilateral, so that's not a great differentiator for the conjunctivitis. If you take a look at the allergic one on the right, you're going to have other symptoms too. You're going to have that red conjunctiva, you're going to be itchy. Itchy is pretty specific for this allergic one. You might feel like you're irritated with the other ones, but it shouldn't really be itchy. And you're going to have watery discharge from there. It's not going to have a significant amount of swelling always, but you might have some other symptoms, a cough, a sneeze, a history of allergies. Whereas the viral one on the left, it's going to look very similar. It's going to have watery discharge, but you're not going to have those other allergic symptoms. It's something that you're going to be able to treat with artificial tears and lubrication for these people. Bacterial, you'll have to treat with some antibiotics for it, usually topical in this case. But there isn't too much else to do for viral and allergic other than take some antihistamines for the allergic. So this is something called chemosis. So if you take a look at this kid's conjunctiva there, you can see that it's actually swollen and filling up with fluid. So this isn't specific to really any pathology in general. This is just kind of a general idea where that conjunctiva gets swollen because there's fluid buildup underneath it. You can often see this in allergic conjunctivitis. You can see this in viral conjunctivitis. You won't typically see this in a bacterial conjunctivitis because they're not having infection underneath that eye right there. And it doesn't always necessarily have to be clear fluid. If you have someone that's in a trauma, for example, it'll look something like this, where you're going to have red blood underneath that. And that by itself, again, is more of a bruising and bleeding into that area. So it's big and scary, and it tells you that something is going on there from trauma, but it doesn't necessarily tell you anything further in. It just tells you that there's swelling, there's blood there, and that this is probably a high mechanism of injury for possible damage to something deeper. Chemical burns are another thing that you can see with the eye. Pretty gruesome in terms of actually looking at it, but you can see why they cause such a problem. So chemical burns, you can have acid burns, you can have alkali burns, and the alkali burns tend to really be much worse than the acidic because they do have that liquefactive necrosis. You have to wash the eyes out like crazy. That's the only thing that's really going to treat this, is getting rid of the inciting agent in the first place. It doesn't mean that it's going to fix any of the damage afterwards, but it's going to prevent things from getting worse. So if you have an eye wash station, that's great. You can also treat with a Morgan lens, kind of like a contact lens that you put underneath the eye right there to help irrigate it. Personally, I found that that can be a little bit hard to tolerate for people, especially that just had acid poured in their eyes, but that is another option. What you can see here with these burns, though, is that they can be threatening for vision in the future, because when there's damage to that outside area of the conjunctiva, it's going to now have scar tissue that comes in, and that scar tissue is going to have blood vessels. So as they go over and they branch, you're actually going to have opacification of the anterior eye, and you'll have diminished vision there. This is another way that you can help flush these eyes out. You take a nasal cannula, you attach it to a bag of saline, and put it down through the eyes. You have them lie there on the bed, and that should be able to get you a good wash out there if you put a liter or two through there. The way that you determine an endpoint for all of these chemical burns is actually with litmus paper. If you put litmus paper in there and it's showing a normal pH, then you're good to stop. Otherwise, if it's showing, depending on what the agent was that went in, an acidotic or an alkalotic pH there, then you want to continue going on with the flushing. This is my dog, just to give your eyes a little bit of rest from all of the other pictures we were looking at before. So now we're gonna kind of, from the very beginning, now before we were at the globe, and now we're more in that anterior area, we're going to talk about cellulitis. So the big thing that we have to figure out with the cellulitis is where is it located. On the left, you can see a preorbital cellulitis, or just really an infection of the soft tissues anterior to the eye. It doesn't get past that blockage there, that really solid septum between the periorbital and the postseptal area. The one on the right is going to be probably something more typical that you would see with a postseptal cellulitis. Here's a great thing that I found to help differentiate between the two of them. You can see that septum here again. So that orbital cellulitis is getting an infection of that soft tissue on the inside of the eye. So like I was saying before, it's going to be painful when you move your eye, because that area that's inflamed, that area that's infected, is all around the eye when it moves. And you might actually get some proptosis if that swelling gets so severe that it actually starts to push the eye forward. And at that point, then you get to worrying about, hey, what's going on with the vision? Is there a deeper infection here? Is this now more serious that we need to do something urgently about? Whereas the periorbital cellulitis, there's no pain in the eye there, then this is just something you can treat with antibiotics and to send them home. So if you think about where that infection is, you have the infection on the outside, anterior to the septum. You also have the infection on the inside, before the septum. Any other infection that we get, there's always a chance of an abscess if that collection gets brought together. Now, if that collection starts to build up, you can get these abscesses. Here you can see on the left the subperiosteal, so it's actually coming from a sinus usually. There's going to be some breakdown between where that sinus is and where the postorbital or postseptal area is. typically you don't get these abscesses, you don't typically get these post-septal cellulitis from just an outside skin infection going backwards and basically pushing its way past the septum. That very rarely happens because usually if you have an infection on the outside of the eye, people will notice that before it has the chance to continue on until the eye and get an infection past it. So if somebody has, say, a sinusitis, there's some sort of trauma, or that sinusitis goes untreated, that infection can then start encroaching behind the eye there. So you can see on the left, the subperiosteal is kind of a spectrum here. It starts to go from the sinus and work its way out. Whereas the orbital one on the right, that abscess is actually formed behind the eye and it's not coming straight from the bone. So we get worried about this. Of course, you're going to have pain there, you're going to have inflammation, irritation there, but you're going to have more proptosis and more pressure there the bigger that abscess gets. And this is something that needs to be dealt with quickly and with IV antibiotics. But the only way that you're going to find these is if you do CT imaging in order to differentiate between whether it's an abscess, whether it's not. They're all going to present relatively similarly in terms of symptoms. They'll change with severity as the infection is worse, but it's going to be difficult to determine whether it's an abscess or whether there's just a post-septal cellulitis without doing a CT scan. There's actually a Chandler classification for this. It's a good representation of the different areas that are infected here. So the type 1 is preseptal, type 2 is postseptal, type 3 is subperiosteal, 4 is an orbital abscess, and actually if it continues on there, then you can get a cavernous sinus thrombosis. It's kind of a continuation of this infection going to different areas. Now, endophthalmitis is an infection of the actual globe itself. Typically, this is something that's post-surgical. The vitreous humor in the eye actually gets infected, and you'll lose vision with this. It's going to be painful. It's going to look terrible when you take a look at it. And this is something that absolutely needs to be seen by ophthalmology and transferred to get this done and get this dealt with. And is very likely going to need an admission and IV antibiotics. Now, here is what I put together, taking a look at all of these things that we were talking about before. This is a chart, a flow sheet that you can use, starting with the red eye and going down to see if you can figure out what exactly is going on. Biggest thing, as you can see at the top, that first branch point is the painful and painless. You take a look at that painless side and you look down at the diagnoses here. You have conjunctivitis, it's allergic, it's viral, it's bacterial. You have episcleritis, you have a subconjunctival hemorrhage. All of these things are not anything that necessarily needs to be seen by ophthalmology, and it's not something that you need to keep in the hospital. This is something that you can send home. So if someone has a painless red eye, chances are you're going to be good to get them going home. Whereas the painful eye is going to be a little bit more complicated. We use tetracaine, we use whether there's an infection on the outside, whether there's blood in the anterior chamber, whether it improves with tetracaine is going to be something important. It's going to help you with a layer of what the where the eye's irritated. So this is something that you could use to help you out and figure out whether or not you need to actually consult ophthalmology or where you might be going afterwards. These are just another couple of things, throw back to the med school eye words. They're all going to be a little bit different of different causes, but whether it's the sclesion, the hordeolum, the blepharitis, the ectropion, all of this is not necessarily something that needs to come in to see ophthalmology, but this is something that you can usually send people home with. These are some more of those words, that hyphema and the hypopion that we were talking about before. On the left is hyphema, it's blood. Hypopion is white. Pyo, it's infectious, so it's going to be bacterial white blood cells. So, and hyphema or heme, so it's going to be blood on the left. The hypopion is going to be telling of infection. This is something that is going to very likely need antibiotics and ophthalmology. Same thing with hyphema. You're going to be calling ophthalmology for this, but for a different reason. If you're having blood coming into the anterior chamber, something is bleeding, and we're going to treat that in the setting of trauma, very likely as an open globe, actually. So this is something that you need to consult ophthalmology for whenever you see it. So I hope that was helpful in helping out the emergency management of the red eye here. If you have any questions or anything, and comments or anything, you can feel free to reach out to me. Here's my email, and if you want a list of my references, you can scan this QR code. Thank you.